Good afternoon, esteemed guests, respected faculties, distinguished speaker, panelists, and dear participants. It is with immense pleasure and enthusiasm that I welcome you all to this highly anticipated session of PSG Med Talks December 2024. Today we gather not only as individuals passionate about medicine and healthcare, but also as a community committed to advancing knowledge, challenging norms, and exploring new frontiers in medical science. We are truly fortunate to have with us today Dr. research.To, a renowned expert in the field general medicine from JIP Multispecialty Hospital, Chennai, who will be delivering an insightful guest lecture on the new emerging concepts in IV fluid therapy. Dr. research.To's extensive experience and cutting-edge research in this area are sure to provide us with a fresh perspective on the evolving role of intravenous fluids in clinical practice. As we all know, fluid therapy is fundamental in patient care, and it's an area where even small advancements can make a big difference in outcomes. Dr. research.To's lecture promises to be both informative and thought-provoking, and we are eagerly looking forward to his invaluable insights. Following this, we are excited to engage in a case-based panel discussion on the topic of when the cough won't quit, unraveling the mystery of chronic cough. I welcome Dr. Balakrishnan, our Professor and HOD, Department of Neurology, Dr. Mukundan S., Associate Professor, Medical Gastroenterology, Dr. Dayanand A., Professor and HOD, Department of ENT Surgery, Dr. Karthikeyan Ramasamy, Consultant, Surgical Gastroenterology, Dr. Sendil D., Consultant, Pulmonology, a quiz master for today. Chronic cough can be a perplexing and debilitating condition affecting millions of patients worldwide. The underlying causes can range from common respiratory issues to more complex systemic conditions. In today's discussion, our esteemed panelists, specialists in pulmonology, ENT, and internal medicine will take us through real-life cases, share diagnostic approaches, and discuss treatment strategies that are shaping the future of chronic cough management. This session is sure to provide us with practical insights and a deeper understanding of a condition that is often misunderstood and misdiagnosed. The format of today's session reflects the very essence of PSG Med Talks, a platform for learning, collaboration, and the sharing of expertise. We aim to foster an environment where students, faculty, healthcare professionals, and experts alike can come together, exchange ideas, and contribute to the ongoing dialogue about improving clinical practice. I would like to take this opportunity to express my heartfelt gratitude to Dr. research.To for joining us today and for sharing his expertise with us. We also extend our sincere thanks to our panelists who have generously agreed to share their time and knowledge for today's discussion. It is now my pleasure to introduce and warmly welcome the moderator for today's panel discussion, Dr. Jayakumar R., Associate Professor, Respiratory Medicine. We are looking forward to an engaging and well-curated session under your leadership, sir. A special thanks to our organizing committee, faculty members, volunteers, and all those who have worked tirelessly behind the scenes to ensure the success of this event. Without their dedication, none of this would have come together as seamlessly as it has. Finally, to all the attendees, whether you're students, faculty members, healthcare professionals, or anyone with a keen interest in medical advancements, I encourage you to actively participate in today's sessions. Your questions, insights, and perspectives are what will make today's event truly valuable. Once again, I extend a warm welcome to you all. Let's make the most of this opportunity to learn, engage, and collaborate. Thank you, and I wish you all a highly engaging and insightful session. Thank you.
Good afternoon, one and all present here. So without wasting much time, I would like to welcome Dr. Neo. When I was going through his CV, I found that he is very much interested in teaching students, nurses, and mainly in the IV fluids management and diabetes management. So without wasting much time, I will welcome Dr. Neo, internist, for this guest lecture.
Before I get into IV fluid proper, just I want to say some words from heart. இன்னைக்கு வந்து ரொம்ப பதட்டமாக இருக்குது. ஆக்சுவலாக அந்த ஐவி ஃப்ளூயிட்ஸ் வந்து ப்ரெசென்ட் பண்ணது பார்த்திங்கன்னா இதோட ஒரு 20th 25th டைம் இருக்கும் அக்ராஸ் தமிழ்நாடு. ஆனால் இன்றைக்கி வந்து பார்த்திங்கன்னா என்னுடைய ப்ரொஃபஸர்ஸ் ஜேஹெச்பி சார் முறையாக வந்திருக்காரு. இந்த டைம் லாஸ்ட் டைம் ஐ ரெக்வஸ்டட் சார், இந்த டைம் நீங்கள் கண்டிப்பாக வரணும், யூ ஷுட் பி த பார்ட் ஆஃப் ப்ரோக்ராம். எல்விகே சார் எவ்வளோ தடவை ட்ரை பண்ணோம், சாரும் இந்த தடவை வந்திருக்காரு. லாஸ்ட் டைம் விமல்குமார் சார் வந்தார். இவங்க முன்னாடியெல்லாம் ப்ரெசென்ட் பண்ணுறதுக்கு கொஞ்சம் ஒரு பதட்டமாக இருக்குது, ஃபஸ்ட் பாயிண்ட். ரெண்டாவது, ஓப்பனாக சொல்லப்போனால் நம்மளுடைய ப்ரொஃபஸர்ஸினுடைய அவங்க ஸ்பௌஸ் வந்து அவங்கள பற்றி நிமிஷத்துக்கு நிமிஷம் நினைக்கிறாங்களோ இல்லையோ, ஐ யூஸ் டு திங்க் அபவுட் தம். ஒவ்வொரு நாளும் 2 நாளைக்கு ஒரு முறை பிஎஸ்டியை நினைக்காத நாளே கிடையாது. இன்ஃபேக்ட் நான் இந்த அளவுக்கு வளர்ந்துருக்கோம், பெரிய அளவில் வர்றோன்னா அஃப்கோர்ஸ் காட் ஆல்மைட்டி இஸ் தேர். ரெண்டாவது, நீங்கள் யூ ஷுட் நாட் ஃபர்கெட் பிஎஸ்டி மாதிரி ஒரு ட்ரெடிஷன் கல்ச்சர் வந்து எந்த இடத்துலையும் இருந்ததை நான் கேள்விப்பட்டதே இல்லை. ஸோ இன்ஃபேக்ட் வி ஹேட் க்ரோன் அப் வித்தவுட் ஹேவிங் இன்வால்வ் எனி கைண்ட் ஆஃப் ரேகிங் ஆர் எனி திங். அப்புறம் ஒண்டர்ஃபுல், அதாவது நம்ம ப்ரொஃபஸர்ஸை பற்றி நினைக்காத நாளைக்கு ஒவ்வொருத்தருக்கும் ஒவ்வொரு ஹிஸ்ட்ரி. நான் ஐ திங்க் தட் இன்னைக்கு ப்ரோக்ராம் 5 o'clock முடியும்னு நினைக்கிறேன். யூ ஷுட் ஸ்டே பேக் டில் 6 o'clock. ஐ திங்க் தட் தெர் இஸ் நோ எக்ஸ்கியூஸ் ஆன் தட். ஒவ்வொருத்தரையும் அந்த ப்ரொஃபஸர்ஸ் அப்படியே வந்தோன்னா, அப்படியே எல்விகே சார் அப்படியே போஸ்டிங் போகும்போது ஒரு பேஷண்ட் கிரானிக் டயரியா, என்ன ரீசன்னே தெரியல. அதுக்கப்புறம் பார்த்தா ஒரு சின்னதாக ஹைப்பர் பிக்மெண்டேஷன். அப்போ சொன்னார், கிரானிக் டயரியா மேபி அ பார்ட் ஆஃப் B12 டிஃபிஷியன்சி. இன்ன வரையும் ஹைப்பர் பிக்மெண்டேஷன் நெயில்ஸில் இருந்ததுன்னா அது மாதிரி ஒரு 5-6 இதாவது நான் வச்சுருக்கேன். B12 டிஃபிஷியன்சி மேனிஃபெஸ்ட் வித் ஹைப்பர் பிக்மெண்டேஷன். வெரி ஃபஸ்ட் இயர் பிஜிலே என் ப்ரொஃபஸர் முன்னாடி சர்ப்ரைஸாக சொன்னது பார்த்து அவரே ஆடிட்டார், எல்விகே சார். அடுத்தது சுஜா மேடம், அவங்கள பற்றி சொன்னால் லேடிஸில் ஃபிஷன் ஒரு ரோல் மாடல். அவங்க இன்ஃபேக்ட் கிளினிக்கலாக என்னுடைய சிஸ்டர் வந்து இன்ட்ராக்டபிள் வாமிட்டிங் couldn't be treated by any other means. She was shifted to PSD under the care of சுஜா மேடத்தில் வந்து வாமிட்டிங்கை க்யூர் பண்ணாங்க. ஸ்டில் நான் ரீகால் பண்ணுறேனோ இல்லையோ, என்னுடைய சிஸ்டர் சி யூஸ் டு ரீகால். விமல்குமார் சார், பொதுவாக அந்த காலத்தில் 1995 த பேட்ச் வேர் ஐ எம் பிலாங்கிங் டு, அப்போல்லாம் பார்த்தீங்கன்னா சர்ஜிக்கல் கேசஸ் சீம்ஸ் டு பி வெரி லோ. அப்போ சாரே தன்னுடைய கோட்டை ஸ்வெல்லிங்காக மாற்றி, தன்னுடைய ஒயிட் கோட்டை ஸ்வெல்லிங்காக மாற்றி அந்த ஸ்வெல்லிங்கை அப்படியே தாஸ் மாதிரியே டிஸ்கிரைப் பண்ணி, அது மாதிரி இன்சிடென்ட். ஜேஎஸ்பி சார் ஒரு தடவை சாரை பார்த்தா, ஜேஎஸ்பி சார் எனக்கு கொஞ்சம் ரஜினி மாதிரி தெரியும் அவர் வேகமாக. அஃப்கோர்ஸ் காம்ப்ளெக்ஷன் இஸ் டிஃப்ரெண்ட், ஆப்போசிட் காம்ப்ளெக்ஷன், ஐ எம் நாட் டினியிங். பட் அவர் நடந்து வர்றது அந்த ஸ்டைல் எல்லாம் பார்த்தீங்கன்னா அந்த ஒரு கார்டியாலஜிக்கு ஒரு டேக். அவர் சொல்லிக் கொடுத்த ஏட்ரில் எக்டோபிக் எப்போ, 1998 ஸ்டில் ஏட்ரில் எக்டோபிக் ஐ எம் வெரி பவர்ஃபுல் இன் டயக்னோசிங் ஏட்ரியல் எக்டோபிக். இது மாதிரி சொல்லிகிட்டே போகலாம், அடிக்கிட்டே போகலாம். பட் ப்ராப்ளி த டைம் வெதர் வுட் அலோ ஆல் தீஸ் திங்ஸ். அதனால அதாவது ஐ திங்க் தட் யூ ஷுட் பி போஸ்ட் ஆஃப் பீயிங் இன் பிஎஸ்டி. தட்ஸ் மை ஹம்பிள் ரெக்வஸ்ட். அதே மாதிரி நம்ம ப்ரொஃபஸர்ஸை ஒரு நாளும் மறந்துடாதீங்க. அது வந்து இன்ஃபேக்ட் நான் ஒரு 10 yearsஸாக உள்ளே வர்றதுக்கு நுழைஞ்சிக்கிட்டு எப்படியாவது பிஎஸ்டிக்குள்ளே நுழைஞ்சி ஐ ஷுட் எக்ஸ்பிரஸ் மை கிராட்டிடியூட்னா எனக்கு வாய்ப்பே கிடையில. ஆனால் இப்போ இவ்வளோ ஃப்ரீக்வெண்ட்டாக வரேன்னா அது காரணம் நம்ம வைஸ் பிரின்சிபல் டாக்டர் ஜே. ஸோ அவர் தான் கட்டாயம். ஸோ ஹி யூஸ் டு என்கரேஜ் ஆல் அவர் அலுமினி கெட்டிங் இன் டு பிஎஸ்டி ஃபோரம். ஸோ இந்த மாதிரி நம்ம போயிட்டே இருக்கலாம். இன்ஃபேக்ட் நான் இன்னைக்கு எல்லா ப்ரொஃபஸர்ஸையும் ஹானர் பண்ண ஒரு லாஸ்ட் 2 yearsஸாக அப்படின்னு நினச்சிட்டே இருந்தேன். இந்த தடவையும் ஹானர் பண்ணலாம்னு நினச்சேன். டாக்டர் ஜே சொன்னார், சார் இது கொஞ்சம் மெட்டாக்குன்னு வேறு ப்ரோக்ராம், அதில் நீங்கள் கொஞ்சம் யூ ஜஸ்ட் ரெஸ்ட்ரெயின் யுவர் செல்ஃப் அப்படின்னாரு. அதனால் ஜஸ்ட் ஒரு 2 members ஹானர் பண்ணிவிட்டு எகெயின் ஐ வில் கம் பேக் வித்தின் 6 months. ஐ வாண்ட் டு ஹானர் ஆல் மை ப்ரொஃபஸர்ஸ். இன்னொன்று சொல்லப்போனால் பால்கி சார், அவரை நான் சொல்ல மறந்துட்டேன். என்ன சார் 92 batch சார், அவர் ஒரு நல்லா படிப்பார், சுறுசுறுப்பாக போவார். ஆனால் ஒன் டே ஐ காட் ஸோ ஹாப்பி தட் ஹி ஹஸ் பிகம் எ நியூராலஜிஸ்ட். அதுவும் தென் ஹீ இஸ் ஹெட்டிங் நியூராலஜி டிபார்ட்மெண்ட்டுங்கும் போது ஒரு அளவில்லாத ஆனந்தம். ஸோ இப்படி எல்லாத்தையும் நம்ம சொல்லிட்டு போகலாம். ஐ திங்க் தட் அதுக்கு முன்னாடி ஒரு 2 பேரை மட்டும் நான் ஹானர் பண்ணிடுறேன். தட் ஐ ஹவ் பின் மிஸ்ட். ஐ கால் அப்பான் ப்ரொஃபஸர் ஜேஎஸ்பி சார். சார் ப்ளீஸ், ஐ வாண்ட் டு கிவ் தட் மொமெண்டோ அண்ட் ஸ்மால் கிஃப்ட். The memento will be given away by our Professor LVK sir. So now please kindly focus on IV fluid and just come out from all your past and recent memories. And what is the advantage of IV fluid therapy? So when you give something intravenously, of course it is accurate. It is accurate, and of course it is controlled by you, and it is predictable way of administration. And second one, as compared to oral therapy, you can expect the immediate response because you are infusing the fluid directly into the blood vessel, or otherwise called intravascular compartment. So what are the indications? Of course, when oral intake is not possible during the time of coma and anesthesia, and during the time of severe vomiting and diarrhea, where probably your oral requirement cannot be met. And second one, moderate severe dehydration, which really warrants IV fluid therapy. And of course, hypoglycemic altered sensorium and hypoglycemic coma requires 25% dextrose as an IV fluid therapy. And vehicle for various IV medication, including dopamine and dopamine, injection noradrenaline, and so on. So when you expect so many advantages, then you are prepared to take on few disadvantages also. It requires strict asepsis, because unless you engage with asepsis, then patient may go for septic shock. And second one, improper selection of fluid. That's very, very important. See, for example, during the rounds, simply you can't say that give normosaline, give ringer lactate. For example, somebody who is harboring hypokalemia, if you give 5% dextrose, that will worsen hypokalemia, because when you give 5% dextrose, that will trigger insulin release from pancreas, then insulin, which in turn sends potassium from the intravascular compartment into the cells. Then in the presence of hypokalemia, you should be very careful. So the proper selection also deserves special mention. And improper volume, that's also very important, especially extreme age group like neonate and older age group, then the meticulous volume should be calculated. Then before we get into IV fluid proper, I want you to rekindle our past and lost memories of physiology. The first one is body water. Surprisingly, our body weight is not only maintained by the muscles and bone, it is almost the 50 or 60% of body weight is maintained by our water. For example, a male weighing 100 kg, then probably he has body water at least 50 kg. So 50% of our body weight is maintained by body water. Then how this body water is distributed? Right. This is the most important slide at which I request you to focus on this. If you focus on these slides, I'm sure you can navigate the upcoming slides. Please remember that please consider this one as blood vessel, or otherwise called intravascular compartment. Please consider this is a blood vessel, otherwise called intravascular compartment. Near intravascular compartment, you have that all blue boxes, all the cells. So adjacent to the intravascular compartment, you have cells. Then in between the cells, you have one space that is called interstitium. Please consider this is blood vessel. Adjacent to the blood vessel, or otherwise intravascular compartment, you have cells. Then in between the cells, you have interstitium. So the spaces that are present inside the cell constitute intracellular compartment. Whatever the space that is present inside the cells, which are present across our body, constitute one compartment that's called intracellular compartment. So other than intracellular compartment, we used to say extracellular compartment. Here the extracellular compartment comprises intravascular compartment plus interstitium. So in nutshell, I want to say our body compartments are divided into two parts. One is intracellular compartment, which is nothing but the spaces inside the cells across our body. Then other than intracellular, extracellular compartment, which in turn is divided into two parts. One is intravascular compartment and another one is interstitium. To much our surprise, 2/3 of our body water is well packed within the cells, or otherwise called intracellular compartment. Suppose if I have 60 liters of water in our body, then almost 40 liters are present inside the cells, otherwise called intracellular compartment. Remaining that 1/3 again will be shared by intracellular, intravascular compartment and interstitium. So what is the significance of these compartment? Even though the water that is present in the intravascular compartment seems to be less as compared to the other compartment, intravascular compartment, or otherwise called blood vessel, plays very dynamic role in our body. Especially it has much impact in maintaining our blood pressure. What I mean? So basically, the intravascular compartment, your blood pressure depends upon couple of the things. One, how your body has the plasma volume. What is the plasma volume that is present inside the blood vessel? That determines your blood pressure. Then what about the vascular tone? How your blood vessel tone, that decides your blood pressure. Then of course cardiac output. So for example, if you have less plasma volume inside the blood vessel thanks to diarrhea or vomiting, then when plasma volume is depleted, naturally your blood pressure goes down. Something like that. When your plasma volume is increased, for example, secondary to chronic kidney disease, naturally your body tends to develop high blood pressure. Something like that vascular tone. When your blood vessel is enormously dilated, especially witnessed in sepsis or any anaphylactic shock, where because of profound nitric oxide causes enormous vasodilatation, produces massive drop in the blood pressure. Something like that. When you are undergoing stress, where adrenaline and noradrenaline, all the hormones are driven from all these glands, and that will make your vascular tone much stringent, or otherwise called go for vascular constriction. Again, BP will go up. So what I want to insist that intravascular compartment plays very spoiling sport sometime in maintaining the blood pressure. And what about the significance of interstitium? Of course, the main significant part in the in pathophysiology of interstitium is in formation of edema. So we used to define what do you mean by edema? Edema is nothing but the fluid accumulation in the interstitium. So whenever more fluid accumulates in the interstitium, then patient will be going for edema formation. What about the intracellular space? So basically, the intracellular space, generally we used to say that whenever patient has hypovolemia, yes, there will be depletion in the intravascular compartment. Sometimes what happens when the patient develops severe hypovolemia, it does affect even intracellular compartment also. The patient who loses 5 liter, 7 liter, for example, in DK or HHS syndrome, where not only there is a depleted plasma volume seen in intravascular compartment, please mindful that even intracellular compartment also faces the tough task of depleted plasma volume. So this is a the simple concept and the significance of the compartments. And what about the distribution of electrolyte? So generally in our body, so-called the electrolytes are there. They're positive atoms, or otherwise called cations. So cations means the atoms that carry plus, that is sodium, calcium, magnesium, and so on. That's called cation. So anion that carries negative, like chloride, sulfate, and phosphate. So how that are distributed, we will see. Let us see. So in the ECF compartment, in the plasma and the interstitial compartment, the most important electrolyte that is present, I mean positive electrolyte, otherwise called cation, is sodium. 90% of our total body sodium is well sequestrated within this plasma and the interstitium, or otherwise called extracellular compartment. Only 10% of the sodium is in the inside the cells. On the other hand, 90% of our potassium is well packed within the cells. In the cells, the predominant cation is potassium. In the ECF compartment, or otherwise called plasma and interstitium, predominant cation is sodium. So where it gains significance? First most important is the potassium. The potassium is well packed within the cells. That's why whenever cell injury occurs, for example, snake bite induced myositis, myonecrosis, or tumor lysis syndrome, wherever cell injury occurs, or any traumatic injury, what happens whenever cell injury occurs, the patient tend to develop hyperkalemia because the enormous amount of potassium released from the cells. That's the way the potassium concentration that is present in the cells gains significance. What about the sodium? So as I told you earlier, 90% of your sodium is present in the plasma. Likewise, the plasma electrolyte concentration is mainly determined by sodium. Probably plasma may harbor many sodium and potassium and so many electrolytes. Plus, please remember that 90% of electrolyte concentration of plasma is almost contributed by sodium. That's the way it is very important. Then, so I have told you about the electrolytes. Now, when you are measuring the electrolytes, that electrolyte concentration is otherwise called osmolality. So osmolality, I think that we would have studied in all Genang and text physiology of Gaitan and so on. So I used to read osmolality. I mean, up to 4 years, I couldn't understand what is osmolality. Then I got failed in general medicine in final year. Then that made me to understand osmolality. So osmolality means it's nothing but it is a solute concentration. I told that you have sodium, potassium, chloride, bicarbonate, everything is there, glucose, urea. So everything is measured, that term is osmolality. So this osmolality, what is the normal value of osmolality is 290, okay? So this is the normal value of plasma osmolality. So among this plasma osmolality 290, please look at the formula. 2 into sodium plus glucose by 18 and urea nitrogen by 2.8. Among which 2 into sodium concentration is around 135. So 2 into 135, almost 270. What I want to say that out of 290 milliosmolality, that is called plasma osmolality, 270 is getting contributed by sodium. For all practical purposes, for us, plasma osmolality is simply synonymous with sodium concentration. If somebody says that the patient develops hyponatremia, then I should assume that the patient has low plasma osmolality. If somebody says that the patient plasma osmolality is low, then I should think that the patient develops hyponatremia. So hyponatremia, I mean the plasma sodium and plasma osmolality is absolutely inseparable. And there are few occasions where glucose may play a role in determining plasma osmolality. For example, HHS syndrome or diabetic ketoacidosis, where the glucose concentration exceeds 500, 600, at the time it may have some kind of impact in plasma osmolality. Otherwise, for all practical purposes, plasma osmolality is nothing but serum sodium concentration. How it is relevant in my day-to-day practice? That's very, very important. As I told you earlier, this intravascular compartment, that's called plasma osmolality. Normal plasma osmolality is 290. It is predominantly determined by sodium. So now we are all aware of all these facts. Now, in day-to-day practice, when somebody develops hyponatremia, or otherwise I would say plasma osmolality becomes less. Or somebody develops plasma osmolality, otherwise called hyponatremia. What happened? As compared to the cellular compartment, now plasma osmolality comes down secondary to hyponatremia. So what happened? One important process occurs that is called osmosis. What do you mean by osmosis? It is movement of water from lower concentration to higher concentration. Now, when you have hyponatremia, what happened? Plasma osmolality is less as compared to intracellular compartment. Now, the water will move out of intravascular compartment into intracellular compartment, which in turn produces cellular swelling across the body. So, when you develop hyponatremia, cellular swelling occurs throughout the body. So, all our organs are, of course, absolutely adapted to accommodate the excess cellular swelling, barring brain. Because brain has been well packed within one rigid structure that is called cranium. So brain can't expand anymore. That is the reason the first most important organ that is vulnerable for hyponatremia is nothing but brain. So, because of hyponatremia that causes less plasma osmolality in the intravascular compartment, leading to the water movement from intravascular compartment into intracellular compartment, cellular swelling occurs anywhere, especially brain ultimately suffers. That leads to cerebral edema. That's the reason hyponatremia always leads to altered sensorium, then ultimately seizures, and ultimately patient lapses into coma, even though hyponatremia can produce some of the GI symptoms. So we witness so many GI symptoms secondary to hyponatremia. They may present with loss of appetite and vomiting. So patient will be bombarded with all neogadin elixir syrup and pandy and everything. The patient might have been on thiazide diuretic, which is notorious in producing hyponatremia. Then please remember that non-specific symptom of upper GI symptoms may be due to hyponatremia. Please beware of that, especially if the patient is on thiazide diuretics, which is commonly prescribed, then you should be very aware of that. So in that way, it's very, very important. Now we come to each and every specific IV fluid. Now 5% dextrose. So what do you mean by 5% dextrose? What do you mean by 5% dextrose? 5% dextrose means 5 gram dextrose in 100 ml. So it is available in 500 ml and 1 liter also. So that means 500 ml of 5% dextrose contains 25 gram of dextrose. 1 gram dextrose can give rise to 4 kilocalorie roughly. That means 5% dextrose, if you infuse 500 ml of 5% dextrose, patient can receive 100 gram of 25 gram of dextrose, or otherwise called 100 kilocalories. The 100 kilocalories means that is equal to almost consumption of 2 idlis. So 5% dextrose will be most important will be helpful in providing the energy. In fact, it can prevent starvation ketosis, it can prevent tissue catabolism and so on. But please remember that 5% dextrose is absolutely devoid of electrolytes. For us, 5% dextrose is nothing but it is a dextrose plus plain water. There is no electrolyte at all. For all our clinical purpose, we consider 5% dextrose as a plain water. Then, where it is useful in correction of hypernatremia. If you ask me how will you define hypomagnesemia, I could easily say the reduction of magnesium. If you ask me what is hyperkalemia, anybody can say the accumulation of potassium in our body. But if somebody asks you what is hypernatremia and hyponatremia, it will be a very, very weird one. Why I am telling? Because the sodium metabolism is absolutely associated with water metabolism. We could say it is almost the lovers. You can't difference and you can't separate between sodium and water metabolism. For all practical purposes, for us, if somebody has hypernatremia, it is not the true excess sodium concentration in his body. It is the water loss in his body that causes relative excess of sodium leading to hypernatremia. I can't say that if somebody has hypernatremia, there is no excess sodium. It is a water deficit that makes sodium seems to be higher. So for us, hypernatremia means there is a water deficit. That means for the treatment of hypernatremia, rather than addressing the sodium concentration, my responsibility would be to fill up the water deficit. As I told you earlier, 5% dextrose is nothing but it's a plain water. So if I give 5% dextrose, then what happens? That will nicely fill your water. Your hypernatremia-induced plasma osmolality will come down. Then it will correct 5% dextrose. That's why any patient of hypernatremia, either patient will be fed with plain water by means of Ryle's tube or 5% dextrose. So contraindication, dextrose, even though dextrose offers few indication, it harbors so many contraindications. So what is the fate of 5% dextrose when you infuse in your body? When you infuse 5% dextrose, 1 liter, as I told you earlier, once dextrose is metabolized in your body, it is a plain water. How our body water is distributed? When you give 5% dextrose, 1 dextrose is metabolized, it is a plain water. How our body water is distributed? 2/3 in the intracellular compartment. So naturally, when you infuse 5% dextrose, 2/3 will enter into the inside the cells. Almost 660 cells will enter into the inside the cells. Only 340 ml will stay back in the extracellular compartment. Now this extracellular compartment should share the rest of this 340 ml. So in the rest of the extracellular compartment will share this 340 ml in such a way that 1/4 will stay back in the intravascular compartment, 3/4 will enter into the interstitium. That means almost only 80 ml will stay back in the intravascular compartment. Or otherwise, I want to insist in such a way that when you infuse 5% dextrose, our intravascular compartment, or otherwise called most dynamic compartment, will receive only 80 ml out of 1 liter 5% dextrose infused. That means in any patient who presents with shock where you need to replete with intravascular compartment, 5% dextrose is absolutely contraindicated. If somebody has lost 1 liter of water, you may give 1 liter of 5% dextrose. You may think that this 1 liter of 5% dextrose may enter into the intravascular compartment, repleting the intravascular compartment. No, only 80 ml will stay back because it is devoid of absolute electrolyte. It doesn't exert any osmolality. So almost 2/3 will enter into the intracellular compartment. Only almost 1/4, 80 ml only will stay back. So 5% dextrose is absolutely contraindicated in shock. So 660 ml 5% dextrose will enter when you give 1 liter. So the most important IV fluid that can offer predominant fluid, whatever you infuse, is 5% dextrose. So wherever intracellular depletion occurs, where 5% dextrose plays a major role. For example, diabetic ketoacidosis. In diabetic ketoacidosis, what generally we do, initially we start insulin infusion, then patient will be repleted with 0.9% saline to enhance your blood pressure. Once sugar level reaches 250, then we will be forced to give 5% dextrose. The why we give 5% dextrose, most of us, what we think, we give insulin infusion. So when glucose level reaches 250, out of fear of hypoglycemia, we give 5% dextrose. No. The first half of diabetic ketoacidosis, you have to replete intravascular volume. That will be repleted with 0.9% sodium chloride. Then rest of second phase of DKA, you have to concentrate on intracellular volume depletion. That will be offered by your 5% dextrose. In that way, 5% dextrose will be very helpful. Otherwise, it is absolutely contraindicated in shock. Then few more theories have been postulated why 5% dextrose is absolutely contraindicated in shock. First, it will stay, only 80 ml stays back in the intravascular compartment. And second one, during the time of shock, what happened? Instead of glucose getting metabolized through aerobic pathway, that is called TCA cycle, under anaerobic metabolism, because during the time of shock, there will be no oxygen to the periphery. So what happened? All the peripheral cells will utilize oxygen, but in the absence of, will utilize dextrose or glucose in the absence of oxygen, otherwise called anaerobic metabolism. What happened? You will have the end product of anaerobic metabolism is lactic acid. So during the time of shock, when you give 5% dextrose, what happened? All the 5% dextrose will be converted into lactic acid, leads to profound metabolic acidosis. As I told you earlier, generally acidosis will cause profound vasodilatation throughout our body, except only one vasculature, that is called pulmonary vasculature. Pulmonary vasculature, where acidosis causes vasoconstriction. That is the reason in long-term COPD patient, where they have profound CO2 accumulation, leads to respiratory acidosis. That acidosis, at the time that acidosis causes pulmonary vasoconstriction, so they develop pulmonary hypertension, subsequently RV failure, carpulmonale. Otherwise, any acidosis will lead to profound vasodilatation. So if you give 5% dextrose, is during the time of shock, leading to lactic acidosis, worsening vasodilatation, leading to further drop in the BP. 2. And third one, if you infuse 5% dextrose more than 500 ml in an hour, what happened? The patient developed osmotic diuresis. More and more glucose will be excreted through the urine. The glucose will drag water along with that, otherwise called osmotic diuresis. Again, you will have plasma volume depletion. All the whole, I want to insist that 5% dextrose should be avoided in shock at any point of time. And it has been perceived that there is an ongoing rivalry between the neurologist and neurosurgeon and between the dextrose. The neuro people, they would love to hate administration of 5% dextrose. As I told you earlier, 5% dextrose, almost 660 ml will be diverted into inside the cells. So most of the time, during the time of stroke or post-neurosurgical procedures, the patient will tend to develop cerebral edema. If you give 5% dextrose will be, all the fluid will be shunted into the intracellular compartment. It will further worsen the cerebral edema. It is absolutely contraindicated. So, few more contraindication, as I told you earlier, it is absolutely contraindicated in 5%, hypokalemia and hyponatremia as well, because hyponatremia, most of the time it is associated with excess water accumulation. If you give 5% dextrose, otherwise called plain water, will worsen your hyponatremia. Then we will come to normosaline. So, what are the contents of normosaline? 5% dextrose, the content is only dextrose. There is no electrolyte. Then what about normosaline? It contains sodium 154 milliequivalent and chloride 154. Is it a misnomer? So we used to say always normal saline. Now we consider this normal saline, the term itself is a misnomer because our plasma contains sodium around 135 to 145, whereas normal saline contains 154, almost 10 milliequivalent is in excess. Our plasma chloride is almost 106 milliequivalent, whereas in normal saline contains 154 milliequivalent. And moreover, even though it says that normal saline, its osmolality also little bit higher. Our plasma osmolality is 290, but normal saline exerts somewhere around 304, 305. For all thing considered, we always say more than it is a normal saline, we could say it is a hypersaline. So what is the fate of normal saline when you infuse in our body? As I told you earlier, normal saline osmolality almost 300. It is close to your ECF osmolality. That means when you infuse normal saline, it will stay back in the extracellular compartment. It won't enter into intracellular compartment because this osmolality closely mimics this electrolyte concentration or osmolality closely mimics with your ECF, I mean plasma and interstitium. So what happens? It will stay back in the ECF compartment. It won't go into intracellular compartment. Again in the ECF, how it will be shared? As I told you earlier, 3/4 should go into interstitium, only 1/4 should stay back in the intravascular compartment. That means when you give 1 liter, 1 liter will stay back in the ECF. ECF will divide the share in such a way that intravascular compartment receives 250 ml, then interstitium receives 750 ml. Please remember that this is the most important IV fluid or crystalloid can give rise to maximum amount of IV fluid in your intravascular compartment. That's why we consider normal saline would be the undisputed leader of choice among IV fluid in resuscitating shock. You may think that if I give 1 liter of normal saline, only 250 ml only it can offer, not 1 liter anymore. No. Then if you ask me, is there any other IV fluid? If I give 1 liter, the entire 1 liter will stay back in the intravascular compartment. Only in the intravascular. If I give 1 liter, the entire 1 liter will stay back in the intravascular compartment. Yes. Few IV fluid, if you give 1 liter, the entire 1 liter will stay back in the blood vessel or intravascular compartment. That is called colloid. The colloids include natural colloids. We used to say albumin. And the synthetic colloids, you have heard about hydroxyethyl starch and gelatin and so on. It is available as Volvin and so many brands. But whenever patient presents with hypovolemic shock, we prefer crystalloids over colloids. You may ask, sir, when you give colloids, almost 1 liter will stay back in the intravascular compartment. Why you can't prefer that colloid rather than crystalloid, which can offer only 250 ml? But what they are telling in the 2021 article, I think that Sepsis Survival Campaign, that clearly demonstrate that with respect to mortality and morbidity, they couldn't find much difference between normal saline and colloid. And moreover, some of the colloids like hydroxyethyl starch have been involved in some kind of controversy in inducing acute kidney injury and so many things. That's why at any point of time, hypovolemic shock, prefer normal saline, bearing few contraindication, prefer normal saline over other IV fluid, even over colloids. So what are the indication? As I told you earlier, first most important, useful in hypovolemic shock because it offers 250 ml of normal saline when you infuse 1 liter. And second one, it is very, very useful in vomiting. So it's a big story. Actually, I have written in few articles in vomiting. In fact, in many of the practitioners I have witnessed for vomiting, they are using ringer lactate. So ringer lactate is absolutely contraindicated in vomiting. So vomiting, how it plays a major role in, how it plays a major role in elevating the pathophysiology of vomiting. So it has been stated that vomiting produces many electrolyte disturbance. You just think about vomiting as a mother. Please consider vomiting as a mother. I want to say something about genealogy of the vomiting. Vomiting consider as a mother. Okay. So the vomiting give rise to 4 kids. Name hypovolemia, hyponatremia, and hypokalemia, metabolic alkalosis. Or otherwise, I want to explain in a little bit detailed way. The vomiting is nothing but it is a expulsion of upper GI contents. Am I right? Diarrhea is nothing but expulsion of lower GI contents. What is the major difference between upper GI content and lower GI content? Upper GI contents are very rich in sodium, whereas lower GI contents are very rich in potassium. That's why in extensive diarrhea, patients tend to develop hypokalemia, whereas during the time of extensive vomiting, patient develops hyponatremia and hypovolemia. So in upper GI secretion, generally potassium is relatively less. So upper GI upper GI fluid contain water, of course, second one sodium, potassium, and H plus, or otherwise called acid. So what happens when you have extensive vomiting? Because water is excreted, hypovolemia, sodium is excreted, hyponatremia, potassium is excreted, hypokalemia to some extent, and third one, H plus is excreted. So H plus means acid. When acid is excreted, body gets into metabolic alkalosis. Here, so vomiting, the mother which gives rise to 4 kids: hypovolemia, hyponatremia, hypokalemia, metabolic alkalosis. The most important pathophysiology, what they are telling, the most important adavadi or otherwise called rogue kid is hypovolemia. They are telling hypovolemia is the one that precipitates rest of all the worsening of the kids. That's a big story. I don't want to get into that. So what they are telling, if you rein in on, or if you are able to control the hypovolemia or otherwise called the rogue kid, then other kids will be subdued automatically. That means if you treat hypovolemia element of the vomiting by means of some form of IV fluid or otherwise called preferably 0.9% saline, then your hyponatremia will be alleviated and your metabolic alkalosis also will be elevated. Then you may ask how metabolic, there will be expulsion of acid. When you give normal saline, how it happens? So metabolic alkalosis can occur by 2 means. One, first most important, because of expulsion of H plus directly from the vomiting, or otherwise, when you tend to develop hypovolemia, one important consequence of hypovolemia is nothing but there will be absorption of bicarbonate from the proximal tubule. When I have severe hypovolemia, there will be avid absorption of bicarbonate from the proximal tubule, which is leading to metabolic alkalosis. So when I offset the hypovolemia with the help of 0.9% saline, when volume status normal, then absorption of bicarbonate from proximal tubule will plummet. So overall, I think that it will be going on something like that. When hypovolemia causes hypokalemia very badly, they are telling potassium not only excreted from the stomach during the time of vomiting, it is a potassium excretion from the distal tubule of the kidney leading to severe hypokalemia in the vomiting rather than from the stomach itself. It is what I want to insist that the hypovolemia, that is a true culprit in pathophysiology of vomiting, for which the best IV fluid is 0.9% saline. And third one, hyponatremia correction. Usually when you find sodium 125 milliequivalent, when you consider it is hypovolemic hyponatremia, for example, due to diarrhea or vomiting, between 125 to 135, when patient is not much symptomatic, we prefer 0.9% saline. When sodium level goes below 125 milliequivalent with much symptoms, hyponatremia-induced symptom, then go for higher concentration, 3% sodium chloride. So what are the contraindication? The most important contraindication, as I told you earlier, if you give 1 liter of normal saline, only 250 will stay back in the intravascular compartment, 750 will enter into the interstitium. So when it gets into the interstitium, more and more fluid accumulation, that leads to edema. That's why the edema, irrespective of the cause, whether it is a cardiac failure edema or renal or cirrhosis, wherever the edema means there is accumulation in the interstitium. Then when you give normal saline, more and more fluid will be diverted into the interstitium. 3/4 of your normal saline will get diverted into the interstitium, leading to worsening of the edema. So it should be avoided. So when we say that normal saline will be the ultimate choice for resuscitation of the shock, then you can ask, is it a celestial IV fluid for all our means? That means, is it absolutely devoid of any contraindication? No. there are two important emerging concepts for a couple of years. So previously, some 10 years, 15 years before, you can give overzealously normal saline during the resuscitation of shock. Now it has been found that if you give normal saline during the time of resuscitation of shock, if it exceeds 2 liter, if it exceeds more than 2 liter, it throws two important complications. One is hyperchloremic metabolic acidosis, and second one is acute kidney injury. What is the reason for acute kidney injury? So what they are nowadays telling, whenever patient is going for impending acute kidney injury, for example, secondary to sepsis or hypovolemia, be careful about overzealous use of 0.9% saline. Why? How? What is the mechanism that behind this concept? As I told you earlier, normal saline contains chloride 154 milliequivalent against our plasma volume of 106. Almost 40 to 45 milliequivalent of chloride is tightly packed within the normal saline. This excess chloride, when it is infused, this excess chloride is excreted in the kidney. Proximal tubule is not able to handle this excess chloride derived from excess use of normal saline. So all the chloride will be diverted slowly into the distal tubule. In the distal tubule, senses the excess chloride, especially macula densa, which leads to constriction of afferent arteriola of the kidney, leads to renal ischemia, then leading to acute kidney injury. Now it has been clearly stated that when somebody presents with shock, 60 or 70 mmHg systolic BP, rush with 0.9% sodium chloride. Make sure that it doesn't exceed 2 liter. When your systolic BP reaches somewhere around 90, switch over to balanced crystal iron, or otherwise called ringer lactate and plasmalate, and subsequent slides will explain. So this is the way it is very, very cautioning. And something called hyperchloremic metabolic acidosis. Whenever you infuse normal saline, they are telling normal saline can dilute your bicarbonate that is present in your body. So you will go for metabolic acidosis. This little bit complicated theory. Then next slide, DNS. So what DNS contains? Normal saline contains sodium and chloride, that's all. DNS contains, in addition to that, you have just dextrose, that's all. So because it contains good amount of sodium, can we infuse DNS in the place of NS in resuscitation of shock? Again, the biggest problem is dextrose. When you rapidly infuse dextrose, patient will go for osmotic diuresis. Dextrose will aggravate lactic acidosis. So the purpose of DNS during the time of vomiting, it will address your energy deficit, and of course normal saline will take care of your all your vomiting pathophysiology. Then ringer lactate. So normal saline contains only sodium and chloride. What about ringer lactate? It contains sodium, good amount of sodium, but normal saline contains 154 supraphysiological amount. It contains little lesser, but please remember that it contains potassium. But normal saline doesn't contain potassium at all, and ringer lactate contains potassium. And the most important peculiar picture of ringer lactate is it contains lactate. So what is the fate of lactate in our body? When you infuse ringer lactate, the lactate that is present in the ringer lactate will be converted into bicarbonate by intact liver. So our liver converts lactate derived from ringer lactate into bicarbonate. That means wherever bicarbonate deficit occurs, for example, diarrhea. So what happened? Diarrhea, as I told you earlier, lower GI contains rich amount of potassium. They will tend to develop hypokalemia. Lower GI fluids contain good amount of bicarbonate. So what happened? I think that you have heard of, media news that Pallavaram area, one water contamination, 4 persons died. So so our hospital received 8 cases. I went through all kind of electrolyte pathophysiology of diarrhea and vomiting. Patient developed severe metabolic acidosis. All the diarrhea, 7 patients we received, all the 7 patients bicarbonate is only 6 and 7 against a normal value of 20. Their potassium is 2.8. Sodium is 130, 131. They presented with 70, 80 BP. Fortunately, all of the patients were resuscitated. 3 of them turned out to be cholera, not, I think that surfaced in the media. So what I want to insist that in any extensive diarrhea, lower GI loss, what happened? Lower GI fluid contains potassium. So all diarrhea patients tend to develop severe hypokalemia. And second one, they will have good amount of bicarbonate in the lower GI fluid. So they will develop acidosis. And third one, hyponatremia and hypovolemia. Please remember that linger lactate fulfills all kind of replacement of electrolytes and acid-base balance lost in diarrhea. In diarrhea, there will be hypokalemia. Of course, ringer lactate offers potassium. Normal saline doesn't contain any potassium, but here it contains potassium. And the most important is when somebody has bicarbonate deficit, you badly require bicarbonate. Ringer lactate offers bicarbonate in the name of lactate. Lactate will be converted into bicarbonate by intact liver. So the most important indication for ringer lactate is wherever acidosis persists, whether in the case of diarrhea, it's a very good fluid, and post-operative status. So because of handling of all kind of tissues and cells, they will tend to develop acidosis. And second one, burns. Okay, and during the time of sepsis. So in most of the situation, ringer lactate would be very, very useful. Only one thing is, ringer lactate really warrants intact liver function. When there is grave defunctioning of liver, or otherwise called, when you have failing liver, fortunately or unfortunately, the ringer lactate, when it is infused, the lactate will not be converted into bicarbonate by our liver. That may lead to sometimes lactic acid accumulation. That's the reason when you have intact liver, most of the time, once BP is around 90, I think that ringer lactate would be a much, much good physiological IV fluid by all other means. So, now previously it has been stated that when you have hyperkalemia, you just hold ringer lactate. If you have hyperkalemia 4.7, 4.8, or when it touches 5.1, 5.2, even 5.5, don't give ringer lactate, because ringer lactate contains, you will have 5 milliequivalent of potassium. Is it so? Yeah, recent literature says that most of the hyperkalemia is associated with metabolic acidosis. Most of the time. For example, the most common cause of hyperkalemia is in day-to-day practice is renal failure. So renal failure, invariably they will be associated with metabolic acidosis and hyperkalemia. What they say, when you give ringer lactate, for example, even during the time of sepsis also you have little bit renal injury, and you will have lactic acidosis, and you will have hyperkalemia and so on. What they are telling, if you give ringer lactate, it releases lactate. Lactate will be converted into bicarbonate. Your acidosis gets corrected. When acidosis gets corrected, your hyperkalemia comes down. So how metabolic acidosis causes hyperkalemia? Metabolic acidosis shifts the potassium from inside the cells into the intravascular compartment. Metabolic alkalosis will drive the potassium from the intravascular into the intracellular cell. Or otherwise, I could say metabolic acidosis and hyperkalemia, most of the time it is commonly seen. Very rarely in diarrhea, you will have metabolic acidosis and hypokalemia. In diabetic ketoacidosis, you will have hypokalemia and metabolic acidosis. Some renal tubular acidosis, you will have hypokalemia and metabolic acidosis. Otherwise, most of the situation, you will have metabolic acidosis and hyperkalemia. Most of the time, sepsis, post-operative status. So, what they are telling, when you have concomitant hyperkalemia and little bit metabolic acidosis, give ringer lactate. It will correct metabolic acidosis. Metabolic acidosis in turn corrects your hyperkalemia. So, hyperkalemia can't be an absolute contraindication for ringer lactate administration, especially in the presence of metabolic acidosis. That's a very, very important new or emerging concept. And next one, whether ringer lactate worsen lactic acidosis. So when you find lactic acidosis, it's partially true and partially wrong. What they are telling, the lactic acid that is produced in our body secondary to sepsis, that also contain lactate plus plus hydrogen. So lactic acid means lactate plus H plus acid. The ringer lactate, what it contains? Lactate plus sodium. Ringer lactate contains sodium lactate. Our lactic acid contains H plus lactate. When you give ringer lactate during the time of lactic acidosis, what they sell, some of the theories, the ringer lactate that is present in the sodium that is present in the sodium lactate can absorb your H plus, so it can correct lactic acid to some extent. So it is not absolutely contraindicated during the time of lactic acidosis. Only for the fear of lactic acidosis in sepsis, don't withhold ringer lactate. That is a concept. So now the evolving indication for ringer lactate, it is not only the familiar diarrhea for which ringer lactate uniformly advocated during the time of sepsis, and second one, when BP goes above 90. So what it has been stated that if somebody presents with BP around 60 or 70, first resuscitate with 0.9% saline. Make sure that 0.9% saline doesn't exceed 2 liters to prevent acute kidney injury or hyperchloremic metabolic acidosis. Once BP reaches around 90, switch over to ringer lactate, because ringer lactate contains good amount of sodium, so it can also elevate your blood pressure, and most of the time during the time of shock you will have acidosis. Normal saline is not capable of correcting acidosis, whereas ringer lactate, which contains sodium lactate, can correct acidosis. So now when you have shock up to 90 mmHg, resuscitate with normal saline. Above 90 mmHg, give normal ringer lactate to make sure that the BP exceeds around 110, 120. Now, the plasma light. Are we using plasma light here? Oh, this is the most sought after fluid in nowadays. So we are using, but actually plasma light is able to elevate blood pressure. Sometimes plasma light is capable of elevating attenders' blood pressure as well. Why? One plasma light cost would be 485 rupees. One ringer lactate something around 50 rupees. So initially I was not aware of all these things. So representative came, plasma light, super molecule, sir, super molecule. Then first 2 days, then in and out I gave plasma light because I was very impressed with the contents, how it acts. So I gave plasma light, almost 5 plasma light per day. So almost 5 patients I gave. Then very next day 4 patients discharged prematurely. Then my staff, I used to ask the feedback from the staff nurse. What happened? Sir, they are telling IV fluid itself, your doctor is giving 2,000 rupees, 2,500 rupees. Then how we can afford it? Then I was quite shocked. Then I looked the literature, then somewhere at 480. So sometimes we should not be caught into some kind of propaganda of all pharmacological material. You should be very aware of that. But bearing the cost, I could say this is a wonderful molecule. Why? Please look at sodium 140. Normal saline contains 154, supraphysiological. Ringer lactate contains 130, lesser than our plasma. Here 140, exactly similar to our plasma. It offers potassium. Normal plasma potassium is 4.5 to 5. This also contains 5 milliequivalent, like ringer lactate. It contains additionally magnesium. So magnesium is not seen anywhere in the IV fluid other than plasma light. It contains chloride, exactly similar to your plasma, because normal saline chloride is around 154. That is the reason they're responsible for your acute kidney injury. Here, 98. And the most important is it contains acetate. It's a good buffer. What I mean acetate? Instead of lactate that is present in the ringer lactate, plasma light contains acetate. What is a peculiar, how it differs from the lactate? So the conversion of lactate into bicarbonate requires intact liver. Whereas conversion of acetate into bicarbonate doesn't require any normal liver function. Even in the failing liver also, you can give plasma light because acetate can be converted into bicarbonate in no time, within 15 minutes. And in fact, you don't require any kind of normal liver function, and its osmolality is exactly similar to the plasma. For all other means, we consider plasma light is a better IV fluid, provided patient affords the things. Now 3% sodium chloride. So 3% sodium chloride. So where it is useful, it exerts higher osmolality. 3% sodium chloride contains somewhere around 1000 milliosmolality per kg. How it is useful? It is very useful in cerebral edema. So previously, all the neurologists, neurosurgeons, they used to use mannitol for cerebral edema. Now it gets fame, 3% sodium chloride. What they have found that as compared to mannitol, because mannitol will cause fluid loss. So when somebody presents with a traumatic cerebral edema where you will have hypotension also. At the time, mannitol can't be given, but you can give 3% sodium chloride. Cerebral perfusion pressure is much good with 3% sodium chloride as compared to mannitol in the cerebral edema. Now it gets fame. I think that now we are using extensively in our hospital. So what is the physiology? If you give 3% sodium chloride, it exerts 1023 milliosmolality. Plasma contains only 300. So you are deliberately increasing plasma osmolality to 1000 in such a way that all the fluid from adjacent intracellular and interstitium will be shifted back into the intravascular compartment. So by giving 3% sodium chloride, you increase deliberately plasma osmolality. This increased plasma osmolality drags the fluid from the adjacent compartment. So your cerebral edema shrinks. Point number 1. And second one, severe hyponatremia. When you have less than 125, as I told you earlier, how it corrects hyponatremia, I think that you can't explain even in a single symposium. It elaborates detailed manner that may unduly confuse you. But please remember that 3% sodium chloride plays a major role in these two conditions. Then we will come to isolate. Almost I am going to end up the slides. So we have so many isolate. I don't want to get into detail. We have isolate M and isolate G, isolate E, and so many things are there. There are 4 common features of isolate. Please remember that all the isolates contains only partial amount of sodium. Normal saline somewhere around 140, 150. Ringer lactate 130, 140. Plasmalate 140, almost equal to plasma. Most of the isolate contains only 40 to 60 sodium. So whichever IV fluid that contains good amount of sodium can elevate your blood pressure. Whichever IV fluid that doesn't contain much sodium can't elevate blood pressure. So all the isolate can't be given in elevating your blood pressure. Point number 1, all the isolate contains rich amount of potassium. That means the conditions where hyperkalemia is present, renal failure, Addison disease, burns, those who are an AC inhibitor or ARB, and so many conditions where hyperkalemia is evident, please avoid isolate, because all the isolate contain not 5 milliequivalent, 10 milliequivalent of potassium, it contains 30 to 40 milliequivalent of potassium. So it is absolutely contraindicated in hyponatremia, absolutely contraindicated in hyperkalemia. That's the most important. All the isolate contain dextrose, so you should be very careful in giving diabetic patient. So I think that almost we are going to end this IV fluid, and in fact, just I want to recollect all your memories. So the most physiological IV fluid, plasmalate and ringer lactate, of course you know, almost the osmolality is similar to that. Best fluid for hypovolemic shock is 0.9% saline. Beware of acute kidney injury and hyperchloremic metabolic acidosis. And fluids to be avoided in renal failure. Be careful about all the hyperkalemic fluid and glucose-free IV fluid, normal saline, ringer lactate, and so on. So I think that I sincerely hope few of the PGs are there. So I have few case studies. Any volunteer is there? Then probably you can answer. Any PG volunteer? You will be awarded, for each answer, you will be awarded 500 rupees. I have brought 5,000 rupees, please. Last time also somebody has been rewarded 1,500 rupees. See, almost, I want to prove that. Okay, so I see, I have been presenting this case for decades and decades, okay. Whether you are right or wrong, you will get rewarded with at least 500 rupees. Any postgraduate or any house surgeons, interns, then don't force me to go for a nurse. You are? Yeah, please, turn up. Yeah. Yeah.
A 34-year-old male, a known type 2 diabetes mellitus patient, admitted with complaints of loose stools 20 times and 3 episodes of vomiting for the past 2 days. History of decreased urine output, especially not passing urine output for the past 6 hours. General examination, patient is conscious and oriented. Temperature is 101 degree Fahrenheit. Tachypneic, respiratory rate is 28 per minute, pulse rate is 130 per minute, feeble, BP is 78 over 60 millimeter of mercury, and systemic examination, CVS, S1, S2 sounds are heard, NVBS, clear RS, abdomen is soft, tender all over the abdomen. Routine investigations, total counts is 21 WBCs, Blood urea 81.4 milligram per deciliter. Serum creatinine is 2.2 milligram per deciliter. Serum sodium is 128. Potassium is 5.4. 5.4. Chloride is 114. Bicarbonate is 15. LFT
Is deranged. That is
Yes.
deranged. Okay. We are running short of time. So, which is the appropriate fluid for this patient and why?
initially
Yeah, please stand up so everybody should see you. Okay. Yeah.
initially we should go with 0.9% NaCl
Why you prefer normal saline?
because the patient has low BP 78/60. We
So,
need to
what about 5% exos? Suppose if I choose 5% exos, what is the disadvantage?
because it goes straight into the intracellular compartment. We need to normalize the intravascular compartment first.
Okay, then yeah, proceed. Then, what about all the isolate?
Because the isolate doesn't contain enough sodium to stay in the intravascular compartment.
Yeah, very good. What about ringer lactate in this patient?
We could start once the blood pressure is normalized because
I think that's very excellently is picking up. So I am really wondering. So I think that the PSG delivers very good CRRI. Okay, fine. And second one, so what you are dealing with? 500 rupees extract so many questions from you. Okay, answers from you. Okay, please. So what are the, what you are dealing with really? So what is the case this patient?
Yep.
So total count 21,000.
WBC sepsis.
Yeah, patient is
fever
sepsis.
is also-
So any other biochemical marker by which you can confirm sepsis?
Low.
Be pro always, proactive, procalcitonin. Yeah, fine. So the patient is in sepsis. So I think that you answered very well. So I really appreciate you. Then so only last question. Yeah, last question, please. 33.
A 33-year-old female presented with severe diarrhea comprising 15 episodes per day for 3 days. She was dehydrated. Physical examination revealed conscious oriented dyspneic. Respiratory rate is 28 per minute. BP is 90/70. Pulse rate is 122 per minute. Investigations revealed CBC is hemoglobin 7.8, MCV is 120, WBC is 21K. Platelet is
1.76.
1.76. LFT is normal. Serum electrolytes, sodium is 132, potassium 3.1, bicarb 12.
So what would be the IV fluid? The best choice would be?
Ringer's lactate.
Yeah?
Ringer's lactate. Because
Ringer lactate. Why not normal saline?
because the BP is
Already
over the
he
target,
reached
90/60.
90. So what is the advantage of oral in this patient?
We could correct the electrolyte abnormalities. Like since we have diarrhea, there is loss of potassium and bicarbonate, so we could correct both.
They're picking up. So the last question I am leaving to you. Hemoglobin 7.8, MCV 120. What you are thinking? So hemoglobin less, MCV is high. So what?
Macrocytic anemia.
Macros. Oh, excellent. I think that you must be a big guy. So what are the differential diagnosis? So hemoglobin. So this patient may not deserve iron therapy. Okay. Iron therapy means MCV should be below 80. So you can't give liberally iron. So MCV, so macrocytic anemia. So either it may be
B12 deficiency.
B12 deficiency,
folate
very good. Then hypothyroidism, liver disease. There's sometimes very rarely hemolysis. Hemolysis also, sometimes macrocytic anemia. So wonderful answer. This is the first time a guy who answered all the questions very appropriately. This is the first time PSG delivered such a, I think that I hats off to each and every professor. And in fact, I really salute this PSG. So this is a place which has offered everything to me. With this, I would like to end up my session. Thanks for giving everything, JSP sir, and in fact, JJ. I want to give. He has brought me and see various occasion, and LVK sir, and so many Vimal sir. I don't sir name sir. Okay, sir. So I don't have any words to express my gratitude. I want to get attached with PSG throughout my life. Thank you. Thank you once again.
Thank you, Dr. Mio, for
Sir, yeah, please come. Whenever I promise, then I will fulfill. Okay, sir. So the way you answered, you are supposed to be rewarded with 5,000, but I'm normally a middle class doctor, so I can't afford. Yeah, please come here. Please. Sure. Excellently you answered. Yeah?
Like I didn't do my medical school in PG. I'm an intern from my family. So
From?
I did in Ukraine, sir.
Ukraine. Oh, Ukraine student, really good. I think that you deserve some more applause. Okay, fine. Yeah, thank you. Thank you. Right.
Thank you, Dr. Neo, for the excellent session, taking us from basics to advanced management of IV fluids. So, due to lack of time, we'll start with the panel discussion. I will invite panelists, Dr. Balakrishnan sir, senior neurologist, Dr. Mugundan sir, senior gastroenterologist, Dr. Dayanand, professor ENT, Dr. Karthikeyan, surgical gastroenterology, and Dr. Sendil, consultant pulmonologist. So we'll start with the case presentation, followed by we will discuss. We'll try to finish quickly because it's already 4:30. So I invite Dr. Kavya, our final year postgraduate students, to present a case.
Good afternoon to my esteemed professors, my colleagues, and everyone present here. Okay. Good afternoon to my esteemed professors, my colleagues, and everyone present here. I am Dr. Kavya Nandini, postgraduate from the Department of Respiratory Medicine. I am going to present a case on the topic when the cough won't quit, unraveling the mysteries of chronic cough. We had a 28-year-old male, Mr. GN, who presented to us with the complaints of chronic cough. He works as a supervisor in a supermarket and his presenting complaint was only chronic cough. The patient had persistent dry cough which lasted for 7 years with no association of sputum production or any specific triggers prior to the cough. The cough is non-productive and occurs at any time of the day but more during the night and early morning hours. Since we are pulmonologists, our first differential diagnosis from the such history was asthma, so we elicited the history, but there was no wheezing, shortness of breath and chest pain, and the cough was persistent all throughout the 7 years. The patient didn't have any fever, weight loss or other constitutional symptoms. There was no history of any recent upper airway infections or chronic or short-term environmental exposures. He also had a gritty or foreign body sensation in the throat preceding the cough. He had occasional reflux symptoms but had increased cough following a spicy meal or when he ate up to his brim, and no history of significant allergic symptoms including rhinitis, asthma or cutaneous atopy. The cough has been progressively persistent and not responding to over-the-counter antitussives and antibiotics. He had visited multiple doctors including pulmonologists, but there was no clinical improvement in his cough. He also had tried native medication upon insistence from his family members and relatives. His past history was nil significant. He did not have any past history except that he had heartburns only for the past 7 years. Prior to that, he had no history. He is a non-smoker who consumes alcohol occasionally and lives in a clean environment with no major exposure to irritants. And he has had suicidal thoughts due to severe cough and poor quality of life. His family history was nil significant and he was taking antihistaminics, various inhalers including inhaled corticosteroids, bronchodilators, proton pump inhibitors and antacids and neuromodulatory agents when he came to us. On physical examination, the patient was not in distress and his vitals were stable. His cardiovascular system was normal, no murmurs or abnormal findings. His ENT examination was suggestive. There was no signs of upper respiratory infections. And his auscultation, he had a clear chest with no added sounds, and his gastrointestinal system examination was also normal. This is his chest X-ray. He had normal lung fields. Even his bronchovascular markings were within normal limits. And these are the cough measurement tools. Based on the symptoms, you have 3 scales: visual analog scale, cough severity score, and cough severity diary. Based on his health related quality of life, we have 2 scales: Leicester cough questionnaire, cough specific quality of life. And objective testings include cough reflex sensitivity. We can use capsaicin, citric acid, tartaric acid, or fog, and cough monitors. Leicester cough monitor and Vitalojac, which record your cough and give us a findings. Based on the visual analog scale for this patient, he had very severe cough, a score of 8. So we proceeded with bronchoscopy and upper GI scopy at the same time, where the bronchoscopy revealed an edematous vocal cords with multiple nodules in the array epiglottic folds and vallicula, and also in his posterior pharyngeal wall, but his tracheobronchial T was normal. On ENT evaluation, the nodules were found to be of lymphoid hypertrophy, and a diagnosis of chronic pharyngitis secondary to reflux disorders was made. In the UGI scopy, he had lax lower esophageal sphincters and grade B reflex esophagitis, and his rapid urease test was positive. Hence, the patient was initiated on H. pylori kit and was discharged. This is his timelines. He initially visited the hospital in January 2023 with chronic cough. He was treated outside. He came to us in March. We planned for UGI scopy and bronchoscopy, and the patient was initiated on PPAs and H. pylori. The cough improved slightly, but he came back till he was taking the HP kit, and he came back to us in August with worsening of the reflex symptoms and cough, which he was very agitated at this time. In January 2024, we again got a gastroenterology review, and he was given a trial of rifaximin with PPIs, but then the patient was lost to follow-up. In July 2024, his cough was so severe that he came back to us with suicidal thoughts. So we counseled the patient regarding fundoplication, and we got a surgical gastroenterology consultation. And they did a 24 hours esophageal pH monitoring, which showed significant reflux. Hence, the patient was planned for fundoplication. In August 2024, patient has undergone laparoscopic Nissen's fundoplication, and following the procedure, the cough was decreased 80% within the first week of the surgery. And currently, the patient is not on any medications, and his cough has practically vanished. Now, we have talked so much about cough. Now comes the question, what is cough? Cough is a reflex action that helps to clear the airways of the irritants, mucus, or foreign particles or pathogens. It is a sudden forceful expulsion of air from your lungs through the mouth. Typically, it is triggered by an irritant in the respiratory tract. It involves 3 stages. First is inhalation, where you take in a deep breath, and then you have a glottic closure and forced expulsion. First, we inhale the air. So, we take in the air around 2.5 to 3 liters of air, followed by a compressive phase where your muscles start contracting but your glottis is closed. And then the expiratory phase, when your sudden release of air at around 500 meter per hour speed. This is the cough reflex act. Receptors, which are present in tympanic membrane, external auditory canal, larynx, supralaryngeal area, trachea, especially in their posterior wall, bronchi, terminal bronchioles, a few in the alveoli, esophagus, pleura, pericardium, diaphragm, and stomach. Via the afferent nerve, which is the vagus nerve, they reach your cough center in medulla oblongata, nucleus tractus solitarius, which also has a higher cortical influence. And via the efferent nerves, the signals are passed on to your muscles so that you cough. So chronic cough, it's not just a nuance but a symptom of an underlying health issue. Timely and accurate diagnosis along with a comprehensive and personalized management is the key to alleviating their sufferings and improving the overall well-being of the individual struggling with persistent cough. Thank you.
Thank you, Dr. Kavya. This is an mainly eye-opener for chronic cough and how the patient suffered due to cough. And for a cough, patient was about to attempt for a suicide. So with this background information, we'll just start with the discussion. So first, I would like to talk to Dr. Sendil. So Dr. Sendil, can you tell what is acute, subacute, and chronic cough? And what is the importance of history taking in these patients, those who are presented with cough?
cough involves asking how long the cough is. Acute cough is usually of very short duration, usually with less than 2 weeks duration. And if at all the patient has an underlying heart disease or lung disease, it can be an exacerbation of the or usually with an underlying disease. If not, no underlying disease, it can be like specific common immunotherapy that is usually goes off within that period of 2 weeks. And the next thing is a little more than that 2 weeks to a maximum of that is a subacute form of cough. Most often this is whatever we see more common now, which is the post-viral illness, and after that, illness usually and the fevers, the cough, the fever will go away, and the acute symptoms go away, but it can go on for nowadays we are seeing longer. It can go over a month, 6 weeks to 1 year. So this is what we call this post-viral. So this is subacute cough, and chronic cough is something more than that, which means that we have more than 8 weeks, which means we have to think of be more complicated. Initial things come more like sometimes when these things are not like the potency, the cough variant, asthma or these are not treated at that point of time. We are even because we are severe. So when it is not correctly addressed at that point of time, this can become a problem. And more sinister ones, which we have to, this is, they say two terms, unexplained chronic cough, and the other one is recurrent or recurrent chronic cough. So which means we know the diagnosis, but it's not identical. It means some kind of effects is going on, like hypersensitivity of the eyes is going on, which is persisting the cough can be there. And the next thing is something being missing. Some unexplained infection, tuberculosis or non-tuberculosis. Some other infection, some infections or non-infectious causes, which we are supposed to go ahead with the and then find out some very bad causes of some symptoms. These are even it's not that those they are simple airlines.
Yeah.
Where the trigger of this can produce.
Thank you, doctor. So careful history, eliciting the careful history is very important to think which direction we have to proceed. So that's the thing. So can you list out? Yes. Site specific. Yes. Yeah. Yes. Yes. Can you list out 4 or 5 common causes of chronic cough in adults? Just.
And next to that comes cough variant asthma, where it actually can even be non-asthmatic.
Yes.
You do not demonstrate either if you are asthma, you not be interested, you can an expert. You can some few tests that you know and just and just cost and
Yes. LVF is one of the causes. Yes.
Actually, they say that it happens during night. The moment they lay out, they have cough. On the 3 things are there. One is the other is
most often there may be some other symptoms, sir, like some breathlessness complaint will be there most of the time. Very rarely it presents with only cough, chronic cough. Yes, yes. We are just discussing.
Also, it can be for chronic also.
Yes, we are just discussing the common causes of in adults. Okay, sir. So, what are the drugs that can cause cough?
Most common is the mechanism that is increases bradykinin or something. So it increases the threshold, lowers the threshold of cough. So it increases so that is one thing. There are other drugs which can predispose to the even
Blocks.
and this also means and other rarer causes will be like
Repeat this. Cough. Yes, this one of the most.
ARVs, I don't think is not proven to these are the commonest.
Thank you, Dr. Sindhil. Next, we'll move on to Dr. Dayanand, sir. Sir, postnasal drip, sinusitis, and upper airway cough syndrome are associated with chronic cough. So, how do you differentiate these upper respiratory causes from other causes like asthma, reflux? Yes, definitely. Definitely. Yes. Okay. Are there any diagnostic methods? Like this patient, sir, we examined from our side, like just like that, we examined the throat. We could not find anything. Later, when we did bronchoscopy, we found a lot of findings. Yes. Yeah, understood. Yes, sir. Yes. Sure. Nasal endoscopy. Yes, yes. Okay, sir. Sure. Sure. Thank you, sir. So now, Dr. Mukundan, sir. So GERD and LPR, that is laryngopharyngeal reflex, are often linked to chronic cough. How will you explain? Like, can you explain how the reflex causes cough symptom?
Okay. Both laryngopharyngeal reflex and GERD-induced cough are a spectrum. Basically, the relationship between cough and GERD, we can put it into two theories. One is called the reflex theory, and the other will be a reflex theory. The reflex theory is nothing but laryngopharyngeal reflex, which is retrograde reflex of gastric contents and gastric secretions into the pharynx, oropharynx, larynx, and sometimes microaspirations into the lower respiratory tract. The reflex theory that has got more evidence is something to do with what we call as the esophageal-tracheobronchial reflex. As we all know, both the trachea and the esophagus arise from the foregut, and they have a common vagal C fiber innervation. So, either end of the spectrum, like if there is a chronic irritation in the esophagus, it can trigger the C fibers in the esophageal mucosa, and it can prime through what we call as neural crosstalk. It can prime the vagal fibers in the tracheal and in the airway, and leading to cough. And it can also be the vice versa, where sometimes the initial insult will be a upper respiratory tract infection, where noxious stimuli can stimulate the vagal fibers in the trachea, and then prime through neural crosstalk the vagal fibers in the esophagus and start the cough. And as I told, reflex and reflex theory, the symptom profile also varies. When you have laryngopharyngeal reflex as the predominant mechanism of cough, the symptoms will be more related to your airway symptoms. And only 30% of them will have typical GERD symptoms. But when it's the reflex theory, that is the esophageal-tracheobronchial reflex, most of these patients have both GERD, typical GERD symptoms, as well as the cough and ENT symptoms. So that will be very, very useful in knowing like what is causing the symptoms. That's the mechanism.
Okay. Are there any diagnostic tools to confirm the GERD other than history taking?
Coming to diagnostic tools, cough related to reflex, there is no gold standard. The first and most important thing and the easiest thing which we can do is give a proper PPI trial, especially in patients who have associated reflex symptoms, typical reflex symptoms. And the second thing will be an endoscopy. Endoscopy can tell you whether the patient has got GERD in the form of esophagitis, but it does not establish that as the cause of cough.
Okay.
So the best method to establish whether the cough is related to GERD will be doing a 24-hour pH study with impedance testing.
Okay.
If you have a 24-hour pH testing which is abnormal, and also the patient has got a laryngopharyngeal reflex, then the chance that this patient will respond to PPI therapy or anti-reflex surgery is very high. But if you have a patient with chronic cough and you do a 24-hour pH study or impedance testing and it is negative, it strongly rules out GERD as the cause of cough.
Understood. Okay, sir. So regarding this reflex study, like 24 hours pH, so do we subject all the patients to
No, as I told you,
24 hours
the first
study,
and
or
best
we'll
thing,
give PPI trial for
always the best thing is to see whether the patient has got only extraesophageal symptoms or they have both extraesophageal and typical GERD symptoms. If they have typical GERD symptoms along with extraesophageal symptoms, and you can very well give a good trial of PPI, 8 to 12 weeks of PPI therapy.
Okay.
And if they have a good response, you continue to treat them as GERD with diet, lifestyle changes, and other modalities.
Okay.
But if the patient has only extraesophageal symptoms, always it is better to involve the other specialities like ENT, pulmonologist, to make sure that you have not missed out other causes of cough. And if you have ruled out other causes, then you go for endoscopy, 24-hour or reflex testing. If the endoscopy and reflex testing is abnormal, you treat as GERD. If again the 24-hour study is negative or normal, then you do the impedance testing, because in impedance you look for non-acid reflex also. If it's still abnormal, then you treat as GERD. If all these tests are normal, then you look for other causes.
Okay, sir. Thank you. So, because we had a case of GERD related cough, just I would like to ask surgical gastroenterologist. Next, I will come to Balakrishnan sir. Next, I will ask. So, what are the indications for surgery in GERD, sir?
So basically, whenever
how will you select the case for reflex like surgeries?
So we generally select cases based on two aspects. One is when the patient starts to demand surgery in these aspects. We generally don't offer surgery at the first instance, but then we offer surgery in two basic aspects. One is when patient demands surgery, and simultaneously the second aspect that we do, as Dr. Mukundan already said, is do a 24-hour pH study and manometry, which proves that there is a positive reflex. So these are the two indications. Of these two indications, we generally combine both together. First is when patient asks. So some of these patients will be on long-term proton pump inhibitors. They would be fed up of taking these medications, and at the same time, some patients may not afford a long-term PPI use with severe GERD. So when these patients come to us, we do a combination of both physical examination, history taking, see the demand of these patients. And at the same time, we do a 24-hour pH study for these patients as well. So only when we have a proof that these patients have a documented reflex, we would offer surgery. Generally, there are a lot of misconceptions that once the surgery is being done, patients will be cured of GERD, which is not true. Sometimes the opposite happens. When we don't do a proper evaluation and offer surgery for these patients, they end up having worsening symptoms, sometimes more in the form of bloating. Because there is a set of patients who are called belchers who try to belch more. And when you put a surgery where we usually offer something like a choking mechanism to these patients, the surgery does a choking mechanism. So they will fail to belch. So they won't be able to belch, which has been habitual for them for a long time. And when you offer surgery which is not indicated, they'll come back, sit on your head saying that the symptoms are worsened. So these are the basic two indications: patient's demand and a proper 24-hour pH study, which indicates that patient has got a document GERD.
Thank you, sir. So what? Yes, sir.
Another point we should note here is If a patient has got good response to PPI, those set of patients are likely to have a good response to surgery.
Surgery.
That is one.
Thank you, sir. So, yes.
So what about pre-lung transplant patients with GI? I mean, I have heard of reports saying that a pre-lung transplant fundoplication improves the outcome of
Lung transplant.
post-lung transplant
Survival.
outcomes. So what is your take on it?
In lung transplant.
Pre-lung transplant evaluation, patient has GI, and post-lung transplant outcomes have been quoted better if at all the patient either they club the fundoplication along with the transplant, or they do a pre-fundoplication and then after that do the
Yes, I've had a few discussions with some of my colleagues regarding this specific instance. Not very common, but then I have still had these things. What they do is lung transplant patients they cannot afford a severe reflex with the gastric contents reflexing back into the airway. So, in spite of patients who fail to, usually they do a 24-hour pH study for all these patients prior to transplant. But then there are certain conditions where even then the 24-hour pH is not indicative of GRD. But if patient has specific symptoms, there are studies and papers which indicate that you do a fundoplication on these patients, provided, as I already said, they don't have the belching episodes. So patient doesn't have a lot of bloating and belching, but then the heartburn is a predominant symptom. So these patients, I've heard that irrespective of a positive or a negative finding in a 24-hour pH study, they do go for a fundoplication.
Thank you, sir. So next, Dr. Balakrishnan, sir. So actually, role of vagus nerve already Dr. Mukundan sir has told about role of vagus nerve and neuro crosstalk, right? Okay, sir. So regarding neurological causes of chronic cough, so how to differentiate these type of coughs, sir, from respiratory or gastrointestinal?
Actually, the neurological cause of chronic cough is very rare compared to maybe like gastro and pulmonary.
Sure.
I think probably I'm going to see patients coming with like chronic cough.
Okay.
But many times they'll come with some other symptoms, like they'll have some other bulbar dysfunction like
Yes.
dysphagia, dysphonia, and they'll have choking sensation, and they'll have cough during feeding, and they'll have some other neurological signs like ataxia, weakness, and other signs. So usually, neurological cause of cough has been described in patients who have a lesion in the dorsal medulla,
Okay.
or who have a problem with maybe cerebral degeneration, or patient who have a maybe higher order like cerebral disorders, like patient who have lesions in the insula, supplementary motor cortex, and prefrontal cortex. So this is very rare. So I think we have centers in higher cortical centers in the medulla, and which is modulated by cerebellum. So if you have any problem in higher cortical areas, which is initiating or inhibiting or modulating like cerebellum and cerebrum, or lesions in the dorsal medulla, can have chronic cough. So, for example, like Armachari malformation, we can have cough, or some demyelinating disorders like maybe multiple sclerosis or neuromyelitis optica, or any compressive lesions of the maybe the medulla. So it's very rare, but many times their symptom may not be the first symptom may not be the cough, but except rarely in Kanawha syndrome, one neurodegenerative syndrome, where they have been described the cough as a first predominant symptom, even like 10-20 years before the onset of the neurological symptoms. So otherwise, rarely the cough may is unusually, it's very rarely is the first manifestation of a neurological disease.
Thank you. Thank you, sir. Sir, regarding one thing, like during my MRCP examination, so I had a neurological case. Finally, I gave the diagnosis of motor neuron disease, but the patient was not having any significant, but he had a nasal voice tone, fine, and he was coughing also. So with the examination, he had some fibrillations in the tongue. So I gave the diagnosis of motor neuron disease, probable pseudobulbar or bulbar palsy. So sometimes patient can come to respiratory medicine OPD with cough, but careful examination of like suspecting
But definitely they'll have some amount of dysphagia.
Yes.
Okay, and
Yes.
they'll have some
So
aspiration.
we are not allowed to take history, sir. That is the problem in the exam. So we have to examine and then we have to give the diagnosis. So it is the thing. So it was a tough case. Anyway, sir. Thank you, sir. So what do you think is the role of speech pathologist or therapist
So
in?
we have severe dysphagia like bulbar dysfunction in many patients like ALS and stroke patients, and even multiple sclerosis or any medullary lesion can cause like lateral syndrome. This is the most common maybe a stroke syndrome of brainstem. They have long they have dysphagia, and they have cough, they have aspiration, microaspirations, macroaspirations, aspiration pneumonia. So we always try to avoid feeding through the mouth, and we put a rice tube. And when the symptoms are we are going to expect is dysphagia is going to be there for a long time, we always do a peg.
Okay.
And but many a time I think patient may not agree for this thing. I think we try to manage with the rice tube, and we just try to stimulate the pharyngeal muscles. We have this very good speech therapy team, Mrs. Pepi, and we have a good this pharyngeal stimulation apparatus,
Yes.
which
I've
improves
seen.
the renal dysphagia in stroke patients very well. So usually we give like for 7 to 10 days of like half-an-hour settings, and many times they recover very fast compared to patients who are not opting for like pharyngeal stimulation. And speech therapists also they just teach the patient to safe swallowing maneuvers to avoid cough and aspiration. So they have a very good role in acute stroke. And any patient who have dysphagia, we always ask our speech therapist to evaluate first what is the strategy, whether it's only maybe physical or just going to use pharyngeal stimulation. We just discuss it ourselves, and according to the patient's affordability, we just do the pharyngeal stimulation techniques and maybe the feeding techniques also.
Okay, sir. Thank you. So we have another two. Yes.
Sir, even in those patients who are not having a neurological cause for cough, the speech therapists have been
Definitely.
specific way
Yeah,
of
that is
swallowing is. Even I told you about this unexplained chronic cough.
So we have reached
Where
palliative
there is-
also, sir.
Where there
Some
is-
cases we have gone for palliative treatment also. Those who are not improving, for example, endobronchial malignancy, extensive compression, cough is not coming down. So we are going up to morphine, and we are referring the patient to palliative also.
I mean to say this is not only in neurological
Yes,
disorders,
definitely.
even in unexplained
Understood.
chronic cough, specific cough methods
sir, yes.
and
Yes.
following methods have been proved to show improvement
Thank
in
you.
cough.
It's our routine in our department. Any acute stroke, we always evaluate for neurogenic cause of dysphagia in all patients. This is a must in all our patients before we start the patient on water feeds. Because one aspiration, they're going to end up in ICU and going to be on ventilator, and the cost is going to be very high. So it's a routine, unless a very small stroke, unless we always refer them to a speech therapist. They come and see all our patients, and we analyze whether they have any dysphagia before we start the patients on be a safe feeding.
Thank you. So one more thing, sir. Just to summarize, when the patient, yes, sir, please.
In fact, this is my personally. We have when we were studying as medical students, and we used to have a reading room in Stanley Medical College hostel. I had a classmate of mine who's the first time I've seen somebody who have a psychological cough. He comes and sits inside. He'll keep on coughing. He will not. I don't know whether he's studying or not. Make sure that once he gets in, everybody will get out. And this is every time during exam, all the 5 years, this man had this psychological cough. So we used to tell him that do something, but probably I think his cough sometimes is a method by which somebody relieves anxiety. And there is another method by which some people, it's like a tick for some people. It's more like, clearing the throat. But I have seen a typical case of this. And unfortunately, the person who was doing it is no more. He actually had a dissecting aneurysm and he passed away a few years back. Absolutely, obviously, no connection. But this is one case I have seen, a psychological cough. During exams, this fellow will have.
So we need to come to that after ruling out all the common causes, sir. Still, sometimes up to 25 to 45% of patients we could not find any cause also as per the literature.
It's like it's called as irritable laryngeal syndrome. So you have to rule out all the cause, and more they say reflux causing this. Even minor symptoms, they start coughing, and the cough itself worsens the symptoms. So it's like a vicious cycle. So they need to undergo psychological evaluation, counseling, and speech pathology also play a vital role.
Larynx. So one last question, sir, to Dr. Sendil. So what are the red flags for specialist referral if the patient is having chronic cough?
So
What are the red flags?
the first thing usually it's commonly described as a cough which has been there for quite some time and a sudden change in the quality of cough. So this, I don't think sometimes the patient might tell you that cough is different from this cough what I have now. So some patients might tell you, sometimes you might have to probe them. And they do come out with, of course, they say that previously what cough was that was different and this is something new which is caused. So we do say that this might be something more than that, which means most commonly it might be some kind of malignancy, especially if it is a smoker. Number 2 is probably the patient had already episodes of aspiration and a foreign body aspiration has happened, and this has caused a post-obstructive pneumonia, and this is something new. This is number 1. Number 2, maybe I would say an occurrence of hemoptysis with underlying cough. So even it can be very streaky. So and that's been there over time, and now hemoptysis occurs. Then this is again a red herring that I would say that it needs definitive warrant further evaluation. And the quality of cough, I would say, of course, for a person who has been there for years together, I would say the patient walks inside with cough, you should be able to tell where the cough is arising from. You will definitely know whether it is from the upper airway or if it is a lower airway cough. And you can judge, okay, this person, you can direct your questions and it will be true. Our history will be, definitely it will be true. So these 2 things I would say.
Thank you. So last question is when there is chronic cough and the examination is normal, so I usually become anxious. I usually involve other people also, gastro and ENT. So is this the correct approach when there is a patient is having chronic refractory cough, not settling down, and there is no obvious cause found? So I think this should be the approach. We should involve.
Yeah, of course.
It should be multidisciplinary approach for the cough. Yes. If the patient's cough is not settling with common causes of, after treating common causes like we discussed, postnasal drip or cough, predominant asthma or GR.
Even I think at present we are having multiple patients with this kind of prolonged cough. We just step up medications step by step.
We treat one condition, another condition will cause cough.
Yeah.
So it should be always.
So it goes on.
Multidisciplinary approach.
Yes.
Thank you, sir. It was nice.
And it is also, I would say, emphasis on judicious investigations, not jump to higher modes of investigation on the first go. We can. Yes.
Most of the time, we'll get some answer.
Most likely, yeah. That is.
Maybe do a basic chest X-ray.
Yeah. Yes.
See and get an ENT evaluation.
Yes. Sure.
And treat the common causes first, then go to rare causes.
Agree.
Thank you. Thank you very much. Thank you, Doctor. Thank you. Thank you, sir. So with this, we'll conclude. Any questions or any doubts? IV fluids also you can ask. Okay, sir. Yes.
Role of actually, if you feel it is, even if you don't find any maybe cause, you can try amitriptyline, gabapentin, and pregabalin. I think this has been documented. We use it for hiccups. So we use baclofen for hiccups, but sometimes we use gabapentin also and pregabalin for hiccups. So we can try these medications if you don't find any other cause. So always just neurological causes very very rare, very very unusual. I think first is ENT, pulmo and GI, then very rarely neurology, and if they say there's nothing is there, you can try these medications. Yeah, I think this decreases the sensitivity of this vagus nerve to the stimulation. So
Those is, I think, comparatively
less.
Neuropathy will give more dose.
Yeah.
This one dose will be less.
So always we start with low dose for any neuropathy. So as like you just start with low dose and increase it.
Thank you.
I just wanted to say one thing regarding this. Initially, I was totally confused as to why a surgical gastroenterologist was called for this panel. So once the case presentation was started, only then I realized that this was the patient which I operated. So when Dr. JSB sir told about his experience on a patient who had a psychological cough, one thing came into my mind because I examined this patient in my OPD. So when this specific person was talking, he used to cough. So in between his sentence, he used to cough, pause for some time and then cough, and then he started to discuss. I initially deferred surgery for this patient because his investigations were not really fitting into the classical criteria of GERD. So, but then the moment I said I will definitely offer him a surgery if he accepts the complication, immediately after that sort of a discussion, his cough stopped. He didn't cough in between. So I was damn sure that when I operate on this patient, there won't be any complication and his cough will stop, provided I'm not really sure if there is a psychological component in this thing. So I was really surprised when JSB sir told that he had also had a similar experience of that and had a tremendous difference even when I offered him surgery. So I felt that this patient would definitely benefit. I've operated on 3 patients with the cough and this one. Yes, he was really comfortable. He was really comfortable. Initially, I was really confused as to why I was called here with panelists like Sendil and Ungundan. And Sendil எல்லாம் பேசினாலே theory medicine கொட்டுவோம். Only when you started talking about the case, I realized that I'm sitting here because of that. Thank you.